I want to start with acknowledgements. First of all, I want to thank all of my patients who have taught me so much about this disease, which is incredibly complicated, and I've really come to appreciate the subtleties of this disease. We're going to talk about a lot of that today. And I want to thank all of you for being here, because you are advocates for your own health. You're empowering yourself, you're expanding your knowledge, you're sharing your knowledge with others, teaching all of us. And you're also contributing to our research efforts. So we appreciate that tremendously. And the hope is that our research efforts will guide us to finding a cure. So what I'd like to talk about today, I'm going to start with an introduction, kind of a framework for how I think about scleroderma and overlap syndromes. I want to define what an overlap syndrome actually is, the importance of autoantibodies, and then we'll kind of do Rheumatology 101, which is just talking about some of the clinical features and my general approach to the management of these syndromes. And then we'll end with some take-home points and questions. So scleroderma, as you all know, or also known as systemic sclerosis, and I think I'll be using SSC as an abbreviation. This is a connective tissue disease that is comprised of abnormalities in the vascular system. We know this because almost all patients will have Raynaud's syndrome, where their fingers will change color as a consequence of abnormal vessels. In addition, we know that people have immune dysregulation. So a lot of patients will develop evidence of autoimmunity, usually in the form of autoantibodies. And finally, this can be comprised of fibrosis, where you end up getting thickening of your skin, in addition, thickening of some of the internal organs. That's an important part of scleroderma. I think the important thing to note is that there's actually a lot of clinical similarities of scleroderma to other connective tissue diseases that we deal with as rheumatologists. So I'm constantly on the lookout for overlaps. In particular, there's been some really exciting, groundbreaking research in the field of scleroderma, and in particular, there's been a lot of advances made by people like Maureen Mays, who's here in Texas, who's done some wonderful work on the genetics of scleroderma. Turns out that a lot of the genes that are dysregulated in scleroderma are also dysregulated in other autoimmune diseases like lupus and RA, which argues that there can be a shared sort of genetic predisposition to a lot of these diseases, so perhaps it's not surprising that overlaps can develop. I always take a very careful family history of my patients, and it's not uncommon that I'll have a patient tell me, oh yeah, by the way, I've got scleroderma and my aunt has rheumatoid arthritis and my cousin has lupus. So again, I listen for this carefully because I think that's a clue to what's driving these diseases. And finally, we're going to spend a little bit of time talking about autoantibodies because I think these are important clues to disease pathogenesis. And what an autoantibody is, it's an anti-nuclear antibody of which most of you, 95% of patients that have systemic sclerosis will have a positive ANA. The type of the ANA that develops helps to define what type of disease develops. And it's commonly found in many connective tissue diseases. So we're going to spend a little bit of time talking about that today. So here's my very simplified view of scleroderma. You have up here localized scleroderma. That refers to scleroderma that just affects the skin and not the internal organs. But what we're going to be focusing on today is systemic sclerosis, which is grossly divided into limited cutaneous and diffuse cutaneous systemic sclerosis based on the amount of skin that's involved. And this is the group of patients that really we're going to be focusing on for this talk today. I want to drive home the point. I promise you this is the only data slide that I'm going to show, but this is actually kind of a good representation of why this disease is so fascinating and so complex. This is a reminder for me to tell you thank you to all of you patients who have donated your time and efforts and tissue to research, because this was a study done by my colleague Kari Connolly, Mike Whitfield, who's in Dartmouth, where they took skin biopsies of patients with scleroderma, and they did what's called a gene microarray, where they look at which genes go up and which genes go down. And this is all based on skin biopsies. And they looked at both limited as well as diffuse patients. And then if a gene goes up, you put it on a chip, and it either turns red when it goes up, or it turns green if it goes down. And each of these columns represents one patient. So essentially, what we found, or what they found in doing this study, was that scleroderma is a very heterogeneous disease. There's not just two subsets, limited and diffuse, but rather there's multiple subsets. In fact, based on this study, maybe at least 5 different subsets. And in fact, they might tell us something also about the disease pathogenesis. So there's this big blob of red right here. These are all representations of genes that are involved in fibrosis. And you can see that this group of patients here has a huge amount of upregulation of these fibrosis-related genes. There's another big red blob down here, and this correlates with the group they're calling inflammatory, because these are genes that are associated with inflammation and activation of the immune system. So you can imagine these tell us that the types of scleroderma can be very different, and in fact may respond differently to different treatments. So this is something that we need to be mindful of when we're thinking about scleroderma, that it's heterogeneous. So a key question has been, what is the cause of autoimmune disease? And we know, I just mentioned that there's been a lot of studies showing that there's genetic components that predispose, and in fact there's shared genes that are dysregulated in multiple autoimmune diseases. In addition, we believe there's some environmental trigger that may somehow lead to the development of autoimmunity. And it's the interaction of these two that will then drive you down a path to develop scleroderma, or potentially some of these other autoimmune diseases like lupus, myositis, rheumatoid arthritis, Sjogren's. I think the million-dollar question is, what are the specific interactions of the genes and environment that drive you towards scleroderma versus one of these other types of diseases? And perhaps it's not totally a crazy idea that some people may develop more than one autoimmune disease. So this is sort of the framework that I use in thinking about autoimmunity. So what's the definition of an overlap syndrome? That's why we're here today. So an overlap syndrome satisfies the diagnostic criteria of at least 2 different connective tissue diseases. The diagnosis is based on clinical features, and which we're going to talk about, as well as autoantibodies. And the most common overlaps that we see in scleroderma are the inflammatory myositis. This is inflammation of the muscle, either in the form of dermatomyositis or polymyositis, rheumatoid arthritis, Sjogren's, mixed connective tissue disease, and lupus. So those are the main ones. There's also various other overlapping conditions that we can see. Thyroid disease is very commonly seen in a lot of our autoimmune diseases. Primary biliary cirrhosis is something I'm going to mention very briefly. And I'll mention that the frequency of overlaps is probably in about 20% of patients with scleroderma, but I'll be honest with you, I see elements of overlaps in probably more than that. So it's just a matter of kind of being aware of this possibility. So this is how I view the world. I think that I see scleroderma in the middle, right smack in the middle, and I basically think that there's a lot of different diseases, I call these sort of flavors of disease, that can overlap with scleroderma, and that things don't always fit into a nice, discrete box, but rather I often see things in shades of gray rather than as black and white. There was a nice study that Chris Denton's group did in England where he characterized 1,700 patients in their registry. They've got a huge number of scleroderma patients. And they went back and looked to see how many of these people met criteria for an overlapping condition. And it turns out 20% of them had some overlapping condition out of the 1,700 patients. And of those, these 4 were the top ones: myositis, rheumatoid arthritis, Sjogren's, and lupus. Lupus was only 8%, myositis being about 43%. In addition, this was the prevalence they found of thyroid disease and primary biliary cirrhosis. So I want to just segue into talking about anti-nuclear antibodies, because this is something that I think you should all be aware of. You've probably all been told that you have a positive ANA, or many of you have. In fact, it's common. I have a lot of patients say to me, oh, I got told that I have a positive lupus test. But actually, ANAs are not just seen in lupus. They're seen in a lot of autoimmune diseases. So I want to spend a little time talking about that. So ANA stands for anti-nuclear antibody. It's frequently found in a lot of different autoimmune diseases. And the pattern is important. So what an ANA is they take these cells and they put your blood onto those cells and see what lights up. And if your blood has antibodies to the nucleus, then you can get these different patterns of staining. There's a speckled pattern, there's a centromere pattern, and a nucleolar pattern. And they all kind of mean something different, because it means this antibody is recognizing something in the nucleus that we like to pay attention to. I want to take one moment here to emphasize to you that it's very important that you ask your physicians to do what's called an immunofluorescence assay, where they actually take cells and put your serum on top of those cells. Because the reason is, Ginny Steen at Georgetown has recently done a study where she found that a lot of centers are using this multiplex ANA, and this is it's a bead assay. It's a slightly different methodology, but I'll tell you, it's a lot cheaper, and so a lot of places are cutting corners by using this technology, and she found that 50% of scleroderma patients had ANAs that were, quote, negative. But in fact, upon retesting by using the immunofluorescence assay, it turns out they were actually positive, and that this multiplex ANA assay just happened to miss a lot of the specificities that are seen in scleroderma. So it's a problem that I think everyone should be aware of, and I think that I just want to bring your attention to it so that you can make sure to ask your physician to confirm it was an immunofluorescence-based assay. I'm going to show you a couple pictures. This is the pattern of what it looks like when you stain cells with your blood, and it lights up in this pattern right here, and that's called a centromere pattern, which is highly specific to scleroderma. And here's a pattern where you see these couple of blobs in the middle of the nucleus, and that correlates with a nucleolar pattern. Let me tell you why that's important. So it's long been known that certain autoantibodies tend to segregate specifically with certain disease subsets. So for example, in scleroderma, there are 3 autoantibodies that tend to be highly specific for scleroderma. And what's interesting is they tend not to be overlapping. So you're either SCL70, which is topoisomerase, positive, or centromere, or RNA polymerase 3, but you don't happen to have multiple ones of these. So these are highly specific for scleroderma. I'll mention to you there's other diseases like lupus, where you can have a double-stranded DNA antibody, you can have a Smith antibody. MCTD is called mixed connective tissue disease, which is basically associated with a high titer of this RNP antibody. I'm losing my pointer here. And inflammatory myositis associated with certain other autoantibodies. This is not for you to memorize. I think you have it on your handout, so I'm not going to belabor this point. But the point is there's been a lot of work that shows the type of autoantibody that develops in a patient will help predict what type of disease they get. I'm going to give you an example of how I use these. I've got a patient who has a positive centromere antibody, and in addition, I screened her for a bunch of other autoantibodies, and it turns out she has a positive SSA antibody, and lo and behold, she has clinical Sjogren's, dry eyes, dry mouth. In addition, she has a positive CCP antibody that's associated with rheumatoid arthritis. And so what am I going to do? Whenever she has joint pains, I'm going to be thinking perhaps she's someone that has a higher risk for developing rheumatoid arthritis, which can lead to debilitating joint disease, joint erosions. So I'm going to be much more wary about screening her. So I think we can use these autoantibodies as ways of putting, as prognostic factors that kind of help guide us in terms of how we provide care to these patients. Just out of curiosity, how many of you here actually have been told you have an overlap syndrome? Okay, so a significant number. Yeah, and I really do feel like it's more common than we realize. I think it's just really important that we need to look. So this is a very busy slide. I'm not going to belabor this point, but the point is that, in fact, there's been some really nice work done by Ginny Steen and Tom Metzger and several others who have shown that if you look carefully at patients that have these specific antibodies, there's actually associations clinically with certain things. For example, anti-topoisomerase or SCL70 antibodies confer an increased risk for the development of interstitial lung disease. So we are very careful about screening those patients and looking for these types of complications. Centromere antibodies, these are people that have limited scleroderma, and they're at risk for increased digital ischemia. Similarly, RNA polymerase 3 in particular gives a highly increased risk for developing scleroderma renal crisis. So we are very, very vigilant about monitoring these patients. And there's a number of other autoantibodies that I'm not going to talk about that we know are associated with certain disease, what we call phenotypes or disease flavors. And there's Ginny Steen walking in the back. So I want to thank her for her wonderful work on really characterizing how these autoantibodies are associated with disease phenotype. The key point of all this is that it's important that we recognize these different overlap syndromes such that we can identify them, diagnose them promptly, so that we can optimize treatment and improve clinical outcome. And the other key point is that actually in many cases, overlap syndromes may be more easily treated and managed than scleroderma itself. So this is why it's important that we understand this. Okay. So we're going to launch into Rheumatology 101, and we're going to kind of go through some of these clinical syndromes that we deal with. The first one is Sjogren Syndrome. So Sjogren syndrome refers to what's called sicca syndrome, dry eyes, dry mouth. This is actually very commonly found in scleroderma. However, there's few patients with scleroderma that fulfill all the criteria for Sjogren syndrome. I will say that from the literature, the incidence of dry eyes and dry mouth is from anywhere between 30 to 70%. In fact, I've got a huge number of patients that have this complication. It's important to realize that often this can actually just be due to the fibrosis that results from scleroderma itself, where you get fibrosis of the glands that secrete tears and saliva. But in some cases, you may actually have true inflammation from infiltration of the lymphocytes into the glands due to a true Sjogren syndrome. Sjogren syndrome can be primary, or it can be secondary to another autoimmune disease. So Sjogren's is probably one of the most common overlaps we see in rheumatoid arthritis. I see Sjogren's a lot. Lupus, a lot of patients will have Sjogren's, secondary Sjogren's. So it's something that we're always on the lookout for. The association is with autoantibodies SSA and SSB, or also known as Rowe and Law. There's other clinical manifestations of Sjogren's, which I won't take too much time to talk about, but importantly, not only can you get dry eyes and mouth, but very frequently patients will have vaginal dryness. You can get a non-erosive polyarthritis. This tends not to lead to the erosions like rheumatoid arthritis, but they can be very painful. Raynaud's can happen as well. And then you can actually get what we call extraglandular manifestations, so beyond the glands of the eyes and the mouth, where you get lymphocytic infiltration into the lungs, the kidney, and the liver, and that can cause some organ dysfunction. So it's important to be aware of that. And you can also have skin vasculitis, even peripheral neuropathy. So the clinical features of dry eyes and dry mouth, basically, in terms of the symptoms that patients complain about with dry eyes, often they'll say it feels like there's a foreign body in my eye, they can have burning, pain, difficulty with making tears, sensitivity to light. A lot of my patients will say, wow, I used to wear contacts and I can't wear contacts anymore. And clinically, what do we look for? We look at the eyes, we look for a decreased tear meniscus when we shine a light on their eye. There's actually a test called the Schirmer test, where they measure how much tear production you have by putting a little strip of paper, it's pretty low tech, a little strip of paper in your eye, and then measuring how much you can make in a certain period of time. And then there's also, ophthalmologists have to do a very good corneal surface exam to look for evidence of abrasions. I'll show you a picture of that in a second. And then in terms of dry mouth, patients they'll complain of difficulty with chewing, with swallowing food. They say, oh, my dentures aren't fitting well. Sometimes patients will get this oral burning, and actually that can be associated with an important condition called chronic candidiasis. This is a fungal infection of the mouth. And you're at more risk for developing this because you just don't produce the saliva that is used to sort of help fight this infection. So clinically, we look for reduced or absent salivary pool. I look for signs of dental decay, and often patients may get cavities. You can't really see this very well, but cavities in unusual places, kind of like right along the gum line instead of in the typical places in the molars. So that's another clue that tips you off. And then I mentioned the chronic erythematus candidiasis. I'm going to show you another picture in more detail. So here's an example where on the left, you can see that this patient, I don't know if you can appreciate, but there's a much redder tongue. There's sort of a flattening of it. You lose the filiform papilla. And then there's this fissuring of the crack in their mouth. This is called angular cheilitis. So these are some of the complications that we can see when someone has candidiasis, chronic erythematus candidiasis. So, and it's a little different than thrush. You guys have probably heard of thrush where you see kind of the cottage cheese things on the top of your mouth. It's different than that. It's not quite so obvious. But again, I think you guys should all be aware that this is a complication that we see not infrequently, and it should be treated aggressively because it can be very uncomfortable, very burning pain, difficulties in general. So again, and you can see following treatment, you see resolution of all these features. How is the diagnosis made? Basically, they take a little lip biopsy and they look at the glands, and it doesn't show up very well, but what these arrows are pointing to are these little dark areas that they basically represent little lymphocytes that are infiltrating into the glands. And they count the number of little spots that are lymphocytes, and if there's a certain threshold that they have to meet to actually make the diagnosis of Sjogren's. And this is called focal lymphocytic sialadenitis. Additionally, I mentioned that you want a good ophthalmologist who's going to do a good fluorescein exam. This is one of my favorite acronyms called P, which refers to punctate epithelial erosions. So when you do fluorescein staining, you can appreciate there's more little punctate lesions. This is one of the more severe cases where you've got severe dry eye and corneal abrasion. Okay, so how do we manage these? So avoidance of medications that exacerbate ocular dryness, so diuretics, trying to avoid those if possible, anticholinergic agents, and examples of these include antihistamines like Benadryl, tricyclic antidepressants like amitriptyline, antidiarrheals like Imodium, and then avoiding irritants like cigarette smoke and dust, trying to maintain a humid environment, taking regular breaks while you're reading, using these spectacle side shields so that wind doesn't blow into your eyes and exacerbate the dryness, and punctal plugs can sometimes help. Using preservative-free tear substitutes. Here's a list of some of the examples of brands that work well. Also, at nighttime, with severe dryness, using a lubricating ointment can help. Restasis is a cyclosporin A emulsion that has been shown to be beneficial in some cases, so I would check with your ophthalmologist to see if it's a helpful treatment for you. And believe it or not, omega-3 fatty acids, there's actually a randomized controlled trial that shows that these do benefit Sjogren's. So that's kind of exciting if you're interested in a sort of less, westernized medicine approach. I'm excited, and then finally, there's a number of medications like cevilamine or Evasac and pilocarpine that can stimulate tear production and saliva production. I'm excited to mention that I recently talked with a good friend and colleague of mine in ophthalmology who wanted to mention that there's this new contact lens called PROS. You can go to this website here. It should be on your handout. Basically, it's this massive contact lens that has a big saline reservoir, and she said that her patients love it. It's comfortable, and it provides really long-lasting protection from the dryness of the eyes. So I will say that, unfortunately, it's still kind of in its trial phase, so there's only a few centers across the country that are using this. UCSF is one. Houston, there's a center in Houston as well. So look that up, go to that website, you can see. But this actually is a really nice way to very safely get saline delivered to your eyes in a longer term fashion. Okay, oral manifestations, it's important obviously to get routine and preventive dental care. And using fluoride gels, prescription strength toothpaste and or oral rinses that contain a lot of fluoride should actually, can be acidic, and, commercially available products can be very acidic and can actually cause irritation of your oral mucosa. So what I tell my patients to look into are biotine products. I think those are quite nice. It's also, I mentioned to you, it's really important that we diagnose and manage oral candidiasis to recognize that this is a complication that's not uncommon, and basically aggressively treat using topical and or systemic antifungal treatments like fluconazole. And then preventing it by discouraging the wearing of dentures overnight, cleaning them well with chlorhexidine, et cetera. Using salivary substitutes or sugar-free gum or lozenges. And then, as I mentioned earlier, using things that stimulate glandular function, such as cevilamine or pilocarpine. Okay, so shifting gears to inflammatory myositis. This is comprised of a couple of different diseases, polymyositis and dermatomyositis. And basically, what is the definition? So this refers to symmetric proximal muscle weakness accompanied by elevation of muscle enzymes. These are CK or aldolase, suggesting there's ongoing muscle inflammation. EMG, this is an electromyogram, which shows evidence of muscular involvement, and this is where they stick needles into you, unfortunately, but they can tell there's certain patterns that are associated with myositis. Often we ask for a muscle biopsy to confirm the diagnosis. And also, if you have dermatomyositis, there are sort of some characteristic skin manifestations that go along with that diagnosis. This is a frequent overlap that we see with scleroderma. It was, in fact, the most common one. I think it was 43% in that one study. And in fact, a lot of these patients will have clinical features that look very similar to scleroderma. And I'll show you that picture. There's actually a nice diagram that I'll go through briefly. And one thing to just point out is that these inflammatory myositis have been associated with an increased incidence of cancer. So in fact, I think it's one thing you should basically be thinking about, could this be what we call a perineoplastic syndrome, where you might have a cancer that could be driving the inflammation of your muscles? So just something to keep in mind. Okay, so the overlap syndromes that we see, the most common one, well, actually I shouldn't say the most common, but one of the ones that's the most well-defined is defined by this PMSCL antibody, which it stands for polymyositis scleroderma. And there is a specific antibody that goes with this syndrome, and I have several cases of this in my patient cohort. The good news is that myositis and the interstitial lung disease that are seen in this case are often less severe and generally more responsive to immunosuppression. So that's a good thing. I also want to make another point that actually a lot of scleroderma patients will have what we call bland muscle involvement. So they may have, their muscle enzymes may not be elevated, but they might have some pains, aches and pains, and some weakness. But this may not necessarily be due to overt inflammation of the muscles. So unfortunately, this tends not to respond so well to immunosuppression. So just to keep that in mind. Okay. I pulled this off the web from someone else's presentation, but I was kind of amused by the fact that I could have literally used this exact same figure to describe scleroderma practically. So these are the systemic manifestations of inflammatory muscle disease, inflammatory myositis. As you see, musculoskeletal, people complain of weakness, there's muscle pain, there can be muscle atrophy, joint-related pains. This can also affect the heart as arrhythmias, sometimes congestive heart failure. These are more rare. GI issues, so problems with swallowing, problems with reflux, which is common. All these things are common in scleroderma as well. There are cutaneous manifestations. There are certain rashes that are more specific to dermatomyositis, but calcification can be seen in both scleroderma and myositis. Pulmonary, there can be aspiration pneumonia from weakness, and also interstitial fibrosis is actually pretty common in this condition, as we know is common in scleroderma as well. And then there can be also sort of constitutional symptoms, and Raynaud's is also common. So there's a lot of similarities clinically with myositis and how it presents, and in comparison to scleroderma. So I just want to point that out. I'm going to show you some examples, some fun pictures of rashes that we see. I don't know, this doesn't come out so well, but dermatomyositis can have what's called a heliotrope rash, where you get sort of redness around the eyes, and it can be, this is a much more sort of dramatic redness, and it can look subtly more like this. This is what I look like when I haven't slept, so again, it can be more subtle as well, but it's something that we're always looking out for. There's a certain sign called Gottrin's papules. These refer to these erythematous little lesions that don't show up very well. Here you can see they basically tend to occur over the joints. So there's a very characteristic looking pattern of the rash that we can see in dermatomyositis. There's also something called the Shawl sign for obvious reasons. And periungual erythema, this is something that can also be seen in scleroderma. And importantly, in myositis as well, we see dilated capillary loops not uncommonly, which, by the way, we frequently see in scleroderma as well. And this is often in the setting of the bad Raynaud's with chronic sort of vascular, vasospasm and lack of sufficient blood flow to the tips of the fingers. Believe it or not, you can also get digital infarction with dermatomyositis, similar to scleroderma. And this is more specific to dermatomyositis. There's a certain finding called mechanic's hands, and maybe you can appreciate why, because it looks like someone's been working on cars all their life, and they get this sort of peeling look about their fingers. But this actually is something that's very classically seen in dermatomyositis, so it's something we're on the lookout for. Here's an example of a muscle biopsy where we took a little piece of muscle and saw that there's lymphocytic infiltration of the muscles, suggesting an autoimmune-mediated attack on the muscle. And then here's an example, something near and dear to my heart, because I focus on lung disease, is an example of nonspecific interstitial pneumonia, which is the most common type of interstitial lung disease that's found in inflammatory myositis, but also in scleroderma. And you can appreciate these are called reticular changes, all these little white lines here. And then you can also appreciate there's some darker circles, holes. This refers to traction bronchiectasis. When you get fibrosis of the lungs and distortion of the architecture, it can pool the bronchi, the conducting airways, and open them up and dilate them. And that's what this is referring to. So that suggests that there are fibrotic changes in this area of the lung. Something to think about and keep in mind. Okay, so how do we manage myositis? Well, As I mentioned to you, the muscle involvement in scleroderma can sometimes be non-inflammatory, i.e. there's no elevation in muscle enzymes, and is more likely related to fibrosis. So this tends not to respond to immunosuppression so well. However, true myositis, when you have inflammation of the muscles, is seen and does respond quite well to immunosuppression. So the major therapies that we use, we often need to use prednisone in high doses, and I'm going to talk about that in a second. Methotrexate works. Imuran or azathioprine is another option, and we're starting to use more and more mycophenolate mofetil, also known as Cellcept. Plaquenil or hydroxychloroquine can be used in cases for skin disease, and for recalcitrant muscle disease, we will often use IVIG. Rituximab, there's some studies out that people think this does work in some cases, so the jury's still out on that. So some of the issues to consider about the treatment of inflammatory myositis when you have concurrent scleroderma. You guys are probably, or hopefully you're all aware of what's called scleroderma renal crisis, and you've probably all been told not to take high-dose steroids. And that is generally true, generally. However, I will say this, if you have muscle inflammation that's so florid and you're so weak and things are not going well, sometimes we'll be pushed to use high-dose steroids. And let me tell you, it actually works quite well for inflammatory myositis. So what do? We use the high-dose steroids, we are aware of the possibility of precipitating renal crisis, and we ask that you monitor your blood pressure really carefully, and that we are very quick to start an ACE inhibitor, which is the treatment for renal crisis, should anything develop, should your blood pressure start to go the wrong way, go up, I mean. So again, sometimes we're forced to use these immunosuppressive agents that may have untoward side effects, but again, it's all about trying to assess risk versus benefit. So keep that in mind. Methotrexate, be aware there is the possibility, it's a rare possibility, of lung toxicity. So we tend not to use that when someone has interstitial lung disease, but if we have to use it, again, we monitor people very, very carefully. And then azathioprine, I just want to, again, one other little educational point, you should make sure your doctors check what's called a TPMT level, either a genetic test or a functional test prior to starting azathioprine. This should be on your handout. I don't expect you to memorize that word, but it's just something that, again, rheumatologists should be aware of, but it's good if you can remind your rheumatologist. Okay, let's move to rheumatoid arthritis. This is a chronic systemic inflammatory disease that chiefly affects the joints and is common, affects 1% of the US population. Women to men, the ratio is about 2 to 1, and average age of onset is about 40, 50. So they recently just revised the diagnostic criteria, but I'm going to just tell you briefly what the clinical features are. Morning stiffness refers to when you wake up in the morning and people are really stiff and it takes a while for them to actually start to feel like they're moving better. That's classically seen. Additionally, often you get arthritis of multiple joints, most frequently involving the hands. Often this is symmetric. And in some cases, patients will develop rheumatoid nodules. And we look for, again, here comes the autoantibodies. We look for rheumatoid factor or CCP antibodies, which are pretty specific. Actually, I'll say CCP antibody is quite specific for rheumatoid arthritis. And then we look for radiographic changes, and by that I mean erosions of the joint. Because the disease is systemic, there can be many features of inflammation that are what we call extra-articular, so outside of the joint as well. And the most common is fatigue. I have a lot of my patients that complain of just feeling really tired. And also there are other manifestations which we're seeing fewer and fewer of, because let me tell you, we've got actually some great treatments for rheumatoid arthritis. So we're not running into these complications so often anymore. Neuropathy, scleritis, vasculitis, pericarditis, pulmonary, and hematologic manifestations. So here's a picture of someone that unfortunately has suffered from rheumatoid arthritis. You can see his joints are really big. He has a lot of these various, this deviation of his fingers. And the good news is we're seeing less and less of this because, like I mentioned, we have better treatments now, TNF inhibitors and others. Here's an example of someone who unfortunately did not get aggressive treatment early on or didn't respond. And here's a normal hand film. And here's their carpal bones of their wrist. And here you can see massive just erosion, distortion, destruction of the architecture. So this poor person probably cannot use their wrist very well anymore. And we're trying to obviously avoid this complication. So how are we managing rheumatoid arthritis these days? Well, prednisone, still tried and true. At low doses, prednisone actually works very well for the joint pains. Non-steroidal anti-inflammatories can be helpful. Methotrexate, I think, has been a very, very important agent that we use for joint disease. And I'll tell you, TNF inhibitors have revolutionized our treatment of rheumatoid arthritis, where patients that were normally debilitated, on disability, are now going back to work. It's been that exciting. And there's a lot of other disease-modifying agents that are coming down the pike that are becoming available for use in rheumatoid arthritis. So what to think about with scleroderma? Non-steroidal anti-inflammatories, great drugs. You can buy them over the counter. Everyone thinks they're safe. Well, they're generally okay if you can use them in sort of limited doses. But just to be aware, scleroderma patients may have an increased risk for GI bleeds. It's common that you have chronic reflux, and gastritis is common. There's what's called GAVE, or watermelon stomach, that can be seen in some scleroderma patients. So you need to be aware of these GI problems that put you at increased risk for GI complications. Additionally, if you have pulmonary hypertension or renal problems, kidney problems, you really should think twice before using non-steroidals. TNF inhibitors, I actually just talked to R.A. Fisher about this because he's seen a lot of patients with interstitial lung disease. And there have been a few reports where they say that there's an increase, there's some case reports of patients where their ILD, their interstitial lung disease, gets worse with the use of TNF inhibitors. He doesn't totally believe that. I think that the jury is still out. So I'm just giving this as a cautionary note, but this is not an absolute contraindication for the use of TNF inhibitors, especially if you have interstitial lung disease. I would say you would want to be monitored very, very carefully. Okay, and we haven't really studied the effects of these other biologic agents so well. There's a lot of different agents I'm not going to go into right now. All right, lupus. How's my time? Okay, so lupus. This is an uncommon overlap with scleroderma. There's a lot of patients with scleroderma that have lupus-like features, but infrequently do they meet all of the diagnostic criteria for lupus. There's a very, very strong female preponderance. It's about an 8-to-1 ratio of females to males that develop this disease. And it's usually younger women. Often the average age is between 20 and 30. So of note, this is younger than the average scleroderma onset. The thing about lupus is that it's always humbling because it can affect any organ in the body in any way at any time. So it's just one of these very difficult, complex diseases. I'll mention the ANA again because it's positive in almost everybody with lupus. It's almost required to make a diagnosis of lupus. So to make a formal diagnosis, you require at least 4 of 11 different criteria, although I'll mention there's many other possible manifestations. So these are criteria that are used for research studies for the most part. There's a number of different skin rashes that can be seen. This is Malar rash, this is the butterfly rash I'll show you a couple pictures of, discoid rash. People tend to report photosensitivity. They go out in the sun and then their skin breaks out in this horrific rash. I don't mean a sunburn, I mean it's a different kind of rash. Oral ulcers are also one of the diagnostic criteria. These are usually painless. There can be an arthritis that develops. This tends to be a non-erosive arthritis. This is different than in rheumatoid arthritis, but it can look like rheumatoid arthritis, but the good news is you tend not to destroy your joints. Serositis refers to inflammation of the linings of the lungs, of the heart, of even the abdomen, and this is called pleuritis or pericarditis, where you have pain when you take a deep breath in. Renal disease is very common in lupus, and there's a number of different renal manifestations. I'm not going to go into the details there. Also, there's a number of different neurologic manifestations. The most common thing patients with lupus say is, I have a headache. That's the #1 most common lupus neurologic manifestation. But also, more concerning, people can develop seizures, psychosis, or other neurologic complications. Hematologic, so there's a lot of blood things that can happen. A lot of patients will have low white blood cell counts, in particular low lymphocyte counts, also low platelets. And immunologic, we talked about some of these autoantibodies. So double-stranded DNA antibodies are pretty specific for lupus. Smith antibodies are also quite specific. And then there's another class of antibodies called antiphospholipid antibodies that confer increased risk for clotting. And then you need a positive ANA. So if you can fit 4 out of these 11 different criteria, then that's how you make a lupus diagnosis. I put this up here only because I don't know if you guys watch House. I think lupus is one of those diseases where, you know, it can do anything at any time, and so probably in every episode someone says lupus is the answer, and I think this is House getting frustrated because it's not always lupus. Okay, so malar rash. Here's an example. Again, these don't project super well, but you can appreciate the redness. This is sort of the butterfly-shaped rash over the bridge of the nose onto the cheeks, interestingly sparing what we call the nasolabial folds. Here's a more dramatic example. This has a more discoid look to it. So that's very classic lupus. Oral ulcers, again, this doesn't project very well, but believe me, there's a little ulcer on the top. These ulcers tend to occur on the roof of the mouth, and more commonly, they're painless, okay? These are not canker sores, this is different. And interestingly, you can get what's called like these discoid lesions. You see these white sort of scaly lesions that can occur in the ear, they can occur on the scalp, you can have hair loss there. And there's also something called subacute cutaneous lupus, which leads to a rash like this. This is associated with the SSA antibody, which is kind of interesting. So there's 1,000 different types of rashes that you can get in lupus. So again, these are just examples. And there's so many things about lupus. I don't even want, we could have a whole conference on lupus. Okay, so the treatment of lupus is really highly dependent on the severity of the organs involved. And really the major therapies that we use, prednisone, again, it works well. Often needs to be used at high doses if you've got a real life-threatening, organ-threatening manifestation. Plaquenil has been shown to be a great drug to kind of keep things at bay and prevent lupus flares. And then, of course, for more severe, like bad renal disease, people will use Cytoxan, Imuran, Cellcept, topical steroids for the rashes, asking patients to stay out of the sun. Again, there's no rule of thumb here. Therapy needs to be tailored to each patient individually based on how severe their disease is. We talked about prednisone a little bit before in the context of scleroderma renal crisis, so being aware of that. But I also just want to take a moment to mention, of course, everyone's aware that steroids, like prednisone, it's all about dose. With high doses, and by that I mean greater than like 15 milligrams a day, you start running into issues, complications such as diabetes, cataracts, weight gain, insomnia, bone loss and osteoporosis, and increased cardiovascular risk. So obviously prednisone works great in a pinch, it works fast, it's a great thing, it's really helped revolutionize rheumatology treatment, but we all know that it's a double-edged sword, and so too much of a good thing is not that good. So just, again, you guys are all aware, I don't need to educate you about that. And in scleroderma in particular, prednisone is something we tend to not use as readily because of the risk for renal crisis. Okay. And then one other point to make here is that with Plaquenil or hydroxychloroquine, which a lot of you may be on as well, because it also actually probably helps scleroderma, is that you should be getting annual eye exams because it's a low risk, but there is a risk for retinal deposition. And then with Cytoxan, Imuran, and Cellcept, you need to have your labs monitored regularly. All right, MCTD. So mixed connective tissue disease is the ultimate in overlap syndrome. It has components of lupus, which we've talked about, scleroderma, and inflammatory myositis, which we've also talked about. And the key features of this disease are high RNP antibodies at a very high titer, Raynaud's, hand edema, arthritis or arthralgias, and myositis. So again, a lot of these clinical features we've talked about in the context of scleroderma, myositis, lupus. So there's a lot, this is the ultimate in overlapping disease. There can be the serositis, pleurisy or pericarditis, esophageal dysfunction, which we see again, that's the scleroderma sort of flavor. Sjogren's is common. It's interestingly very rare in MCTD to get renal involvement, which is a good thing. Skin, there's multiple different manifestations. You can have more of a scleroderma flavor where you have the sclerodactyly, you can have calcinosis and telangiectasias. You can have the more lupus flavor where you have photosensitivity, you can develop some of the classic lupus rashes, or you can have more of the myositis flavor with dermatomyositis types of rashes. So again, anything is game. Interstitial lung disease can happen in some cases. Pulmonary hypertension is the big thing you want to really avoid. And so we screen these patients very regularly for that. Of note, a lot of these patients end up ultimately evolving into more of a lupus or a scleroderma disease type. So again, we follow patients very carefully over time. And here's just an example of an image that I stole from Springer of the puffy fingers that we see in MCTD. And these patients classically will have Raynaud's, and they have a lot of similarities to scleroderma, so I'm not going to show a lot more pictures here. The management really involves, as I mentioned, regular screening for the complications. So we really want to try to avoid pulmonary hypertension, so we have annual echocardiograms, and also to avoid interstitial lung disease, we try to screen regularly with pulmonary function tests. Occasionally, we might get a baseline high-res CT, but most likely, more commonly, we use regular PFT testing. And like I said, watching patients over time to see how they evolve, either into lupus or scleroderma. And the therapies, again, I'm not going to talk much about this because it depends on what the predominant disease manifestation is. Okay, and just a couple of minutes to just briefly talk about thyroid disease, which is a very common thing that we see. Commonly seen in not only scleroderma, but I see it a lot in our RA patients, lupus patients, you name it. It's just a common thing, and I think, again, because the genetics are shared in a lot of cases, it's not surprising that these overlaps happen. Typically, Hashimoto's thyroiditis is what we most commonly see. I'm routinely screening all my patients with regular thyroid function tests, and by that I mean I look for TSH as well as a free T4. I also will, at initial visit, I will screen patients for the autoantibodies that are associated with autoimmune thyroid disease, anti-thyroid peroxidase antibody or anti-thyroglobulin antibodies. Most commonly, so just FYI, it's actually common to see hypothyroidism in scleroderma, and this may not necessarily just be to inflammation from like a Hashimoto's thyroiditis, but it can actually just even be from the fibrotic process of scleroderma itself, so to keep that in mind. And treatment is with thyroid hormone replacement. And then I'm just going to very briefly touch upon primary biliary cirrhosis, which you should be aware of. Again, I think it was 4%, so pretty infrequent, but most frequently in women ages 40s to 60s. This is a chronic progressive disease that leads to destruction of the bile ducts, and if untreated, it can lead to end-stage liver disease. So it can be seen in association with autoimmune thyroiditis, Sjogren's, and mostly limited, not diffuse, but limited scleroderma, which we formerly referred to as CREST syndrome. We try to avoid that these days, but limited. Most commonly, patients will present with fatigue, with itching. They can have increased pigmentation of their skin, a lot of joint complaints, Sika syndrome, dry eyes and dry mouth. And in the lab, when we look at their lab studies, you'll note they have elevated alkaline phosphatase enzyme. Anti-mitochondrial antibody is the antibody that's been highly associated with primary biliary cirrhosis. And if there is an anti-nuclear antibody, often it's in the centromere pattern. And as I mentioned, this is more commonly seen in the limited scleroderma group of patients. So good news is that early treatment using this ursodeoxycholic acid has actually really significantly impacted prognosis. And I have patients that are 20 years out now that are doing fine. So that's the good news. So how do I know if I have an overlap? I would recommend careful screening upon initial diagnosis. So what I do with all my patients is when I first meet them, I kind of do a very detailed clinical assessment, get their family history, really take a look at everything, and then I send off a bunch of lab tests. And some of my patients, they actually, most of them are grateful. They said, wow, you really turned over every stone there, and I apologize for bleeding them so much. But it's actually important because, as I mentioned to you, these antibodies have prognostic significance. And so I think that's really the take-home point, is that it's good to know so that we can kind of identify if a complication comes up, we have some heads up that might happen. I also, again, evaluate them for muscle enzymes, thyroid tests, et cetera, and very careful follow-up and subsequent screening based on any symptoms that develop. I think the most important thing is having a really good team of doctors who are familiar with these diseases. I like to encourage patients to try to go to an academic center, especially one that specializes in scleroderma, because these are rare conditions. And I'll tell you that at UCSF, where I've been referring a lot of my patients to other specialists, ophthalmologists, GI doctors, lung doctors. We all work very closely together. And so they are now seeing a lot of scleroderma patients as well, and they're garnering experience with these conditions. So I think it's really important, and I don't mean like you don't need to go all the time, but just to check in and have an academic rheumatologist that focuses on scleroderma. And really, the rheumatologist's role is as the quarterback. They should be really kind of guiding your care, overseeing everything, and assuming kind of all responsibility. There are no rules, no hard and fast rules. Every patient is different, individual, and I think it's really important to keep an open mind. Things can evolve over time. I think that, again, I see the world as multiple different shades of gray. Things aren't always black and white, so I think that's really important. The take-home points, just to reiterate, that we talked about earlier how scleroderma is a heterogeneous disease, that we've been learning there's many shared genetic factors between scleroderma as well as other autoimmune diseases, and so this actually provides some explanation for why overlaps happen. About 20% of scleroderma patients will officially develop an overlap syndrome. However, as I mentioned, many of my other patients will have overlapping features. They may not meet diagnostic criteria for another, actual connective tissue disease, but I'm always looking. Autoantibodies can help determine the type of disease that may develop, and in your handouts you have a pretty long list of a lot of these detailed autoantibodies. The most common overlaps are Sjogren's and Myositis, but again, we talked about a few others that exist. Treatment should really be geared toward the clinical picture, and everyone, again, has an individualized sort of treatment course. I think one thing you guys have probably appreciated by being at this conference and talking with, friends and other people that have scleroderma is no one person has the same disease. Everyone is very different, everyone is very unique. And so that's what makes this complicated, but important that we recognize and acknowledge this heterogeneity. And then I think we spent a little bit of time talking about some of the side effects or adverse reactions, just educating you on some of the medications that we should be aware of that could cause problems. High-dose steroids, trying to avoid them if possible, but if you can't, you just need to monitor very aggressively. And most importantly, I think you guys are here because you are informed, you guys are empowered, and I think that, again, you're the ones that are going to do well because you are the ones that have the knowledge. And the good news is that overlaps actually are more easily treatable in many cases than scleroderma itself, so that's actually a good thing. So I want to say thank you guys for your attention, for being here this morning. I want to thank my colleagues. I work at UC San Francisco in a scleroderma clinic with various rheumatologists. Kari Connolly is also a dermatologist. We work very, very closely with the Interstitial Lung Disease group, as well as with the lung transplant group. And I'm just going to make one quick pitch, which is we're about to publish a paper on the UCSF lung transplant experience, which has shown that our outcomes are very good. In fact, it's very exciting because I don't know if any of you guys have heard, but a lot of transplant centers do not transplant scleroderma patients because they're worried about outcomes. We do. And we are going to publish that these patients are doing just as well as other patients as well. So I think that's important. But I work very, very closely with the lung guys, and they're fantastic. I want to thank my colleagues at Stanford. We're forming a Northern California Scleroderma Research Consortium, which really we're hoping is going to build on our knowledge base and facilitate some of these important studies that need to happen. I want to thank the Northern California chapter and the Scleroderma Foundation in particular for inviting me. Jamie, Kate, Kathy, Eddie. They've been a wonderful group. You guys have a wonderful foundation here. I very much appreciate all the work everyone has done. I want to thank all of you who inspire us and really make our work possible. So with that, I'm going to end. If there's any questions, I think my contact information is all at the back of the handout. But thank you for your attention. Appreciate it.